بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the third lecture in the series of spinal imaging, and in this lecture we will deal with the spinal infection and inflammatory lesions. And the spine, as you know, we have two main issues: the spinal cord, inflammation of the spinal cord, and infection of the vertebral column. The inflammations of the spinal cord include the transverse myelitis, MS, multiple sclerosis, radiation myelopathy, sarcoid Behçet syndrome, necrotizing myelopathy, and acute disseminated encephalomyelitis or ADAM. The infectious lesions affecting the vertebral column are either due to biogenic organisms, due to fungi, parasites, or viral infection. The spinal cord inflammatory lesions will all present by almost similar MRI findings, and these include decreased signal in the T1 and increased signal in the T2. And if you inject a contrast medium, there may be enhancement or may not be, you see, you sometimes can see enhancement, and sometimes you do not see enhancement. Also, in some cases, the cord is swollen, and in other cases, the cord is not swollen and is of normal size. These are the main causes of myelopathy, and as I have said, they always or almost show the same MRI findings. Then in the vertebral column, the inflammatory organisms will lead to affection of the vertebral body, leading to osteomyelitis, inflammation of the disc, leading to discitis, inflammation of the inside of the spinal canal will result in epidural abscesses or subdural abscesses, or inflammation of the arachnoid membrane, leading to arachnoiditis. And finally, you got cord inflammation in the form of myelitis or intramedullary abscess formation. And we start first by the cord pathology, and the first lesion in this category is the transverse myelitis, and this is not a disease. It is a clinical syndrome that is caused by many etiologies, and these include inflammations, infections, vaccination, and some of the immune system disorders like the systemic lupus and multiple sclerosis. In all cases of transverse myelitis, you got a non-specific MRI findings in the form of abnormal intramedullary signal. You know that the cord normally shows intermediate signal in the T1 and T2 weighted images. In cases of transverse myelitis, you got in the T1 you may not appreciate any lesion, but in the T2 weighted image you can see usually you see this a long segment of abnormal signal inside the substance of the cord, and this signal is of course increased in the T2 weighted images. Sometimes you may feel that the cord is swollen and in other patients you can feel that the cord is of normal size, and here you may feel some or minimal swelling of the spinal cord. This is an example of transverse myelitis by MRI T1 weighted image and T2 weighted image. In the T1 you may not appreciate the lesion because it is almost vaso-intense signal to the substance of the cord, while in the T2 weighted images you can see there is diffuse increase parenchymal signal of the spinal cord. This is also an example of a female patient, 36 years old, with acute quadriparesis Then you see in the sagittal T2 weighted image a long segment of intramedullary high signal intensity extending from C2 down to D1, for example, or even D2 level. Then this is also an example of transverse myelitis. And this MRI sagittal T2 weighted image of the cervical spine, there is an extensive intramedullary high signal intensity involving most of the cervical spinal cord and extending to affect the upper dorsal spinal cord as well. Then this lesion can be explained on the basis of the clinical situation of the patient, and sometimes it can be a manifestation of MS in the spinal cord or multiple sclerosis, and maybe a manifestation of ADEM or acute demyelinating encephalomyelitis, depending on the patient clinical condition. Then you know that transverse myelitis associated with optic neuritis is known as Debek's syndrome, and in many cases you see an intramedullary high signal in the spinal cord with or without a slight cord swelling. You may think of MS as the most common underlying etiology of this appearance. But you should remember also that any form of myelitis may result in similar situation. In the multiple sclerosis, you know that MS is a disease of unknown etiology, and mainly seen in the brain parenchyma, but it can also affect the spinal cord. And there is a good percentage of patients which have a spinal cord affection reaching about 30%, and the segment of the cord commonly involved is the cervical spinal cord in most of the cases, but you can also see other lesions in the dorsal cord. The lesion will appear as a focal or less commonly diffuse area of signal abnormality. It cannot be usually appreciated in the T1, but it will be seen in the T2 weighted image as an area of high signal. Then if you inject contrast media and the lesion shows enhancement, this means that this lesion is active, exactly similar to the lesions in the brain. And the lesions in the brain are usually not appreciated in the T1, they are seen in the FLAIR and T2 weighted images. And if you inject the contrast and the lesion is enhanced, then you can assume that these lesions are active based on contrast enhancement. The association of brain lesions and the spinal cord lesions is well known in the literature, and it may reach about 30% of the cases. And we used to do brain MRI whenever we are confronted with a case of cervical spine MRI with multiple or single focal lesions of high T2 signal inside the spinal cord, thinking that this may be an MS or multiple sclerosis. And in the brain scans, whenever we see other focal lesions in the white matter, particularly if they are close to the ventricle, as you can see here in this FLAIR image, and also in the T1 post contrasting, you can appreciate that the lesion is somewhat enhancing, denoting activity of the lesion. In ADEM, and I have explained this inflammatory process in the lecture of the brain infection, and this is an acute demyelinating disease which affects the brain, and sometimes it can also affect the cord. The diagnosis of acute disseminated encephalomyelitis depends mainly on the history, since the appearance in the brain as well as in the spinal cord may simulate the appearance of MS plaques. and sometimes the clinical features of both lesions may overlap. Then the presence of recent viral illness or history of recent vaccination within 10 to 15 days before the appearance of the symptoms and the appearance of the lesions in MRI is suggestive of acute demyelinating encephalomyelitis. The lesions will appear of low signal in the T1, high signal in the T2, and the flare in the brain, and high signal in the T2 weighted images in the spinal cord. And if you inject the contrast media, lesions may show contrast enhancement, but commonly they do not see enhancement. And also you should remember that ADEM, or acute disseminated encephalomyelitis, is a monophasic disease, meaning that there is no remissions or exacerbations. But recently in the literature they have reported some cases of clinically diagnosed acute disseminated encephalomyelitis with a remission and an exacerbation. They said that this is accepted if it occurs within the year of developing the disease, meaning that within 12 months duration of the disease may show some remissions and exacerbations. But the MRI findings are almost similar to the appearance of the MS. However, the acute disseminated encephalomyelitis sometimes may show hemorrhagic foci, and of course hemorrhage is not usually seen in cases of MS. And if you look here and you see that the spinal cord is swollen, it shows faint low signal intensity inside the substance of the cord in the T1 weighted image that turned to bright signal in the T2 weighted image. And this appearance without a known history then is diagnostic of transverse myelitis. But if you know that this female child has developed the sudden onset of numbness and weakness in both legs with urinary incontinence, this is okay for transverse myelitis as well. But how can you predict that this is acute disseminated encephalomyelitis? It is the history of recent flu-like attack or a recent vaccination within 10 to 15 days before the onset of these symptoms and the appearances of these MRI abnormalities in the spinal cord. Then this patient has quadriparesis for 6 weeks, and there is no history of recent vaccination or viral infection. Then you can look here, and the spinal cord is markedly swollen. It shows diffuse decreased parenchymal signal in the T1, diffuse increased parenchymal signal in the T2 weighted images. Then after contrast injection, and you can see multiple leptomeningeal enhancing nodules along the dorsal aspect or the posterior aspect of the spinal cord. Actually, these appearances, especially in this history, cannot suggest the possibility of acute disseminated encephalomyelitis. This appearance can be also seen in cases like sarcoid, for example, and in cases of leptomeningeal metastasis as an alternative for the diagnosis. But in order to reach this diagnosis, there may be the other appearances in the brain or in the laboratory findings. Then radiation myelopathy is changes in the substance of the spinal cord secondary to irradiation, usually for neck malignancies. Like in this case, there is radiation for laryngeal carcinoma. The spinal cord is swollen. it shows diffuse into increased signal in the T2 weighted images, and after injection of contrast you can see a linear irregular enhancement. In the case in the positive history of radiation, previous irradiation, it is easy for you to predict that these changes are usually the sequelae of irradiation. And you should remember that there may be a latent period between the onset of irradiation and the development of lesions in the spinal cord, which may be in the range of 12 months to 28 months. Then the changes are in the form of decreased signal in the T1, increased signal in the T2, a slightly swollen cord, and there may be foci of contrast enhancement, as you can see here. And later on, the cord will develop some atrophic changes. This is also radiation myelopathy, and you can see that the spinal cord is slightly swollen. It shows a long segment of diffuse parenchymal increased signal intensity, and you can easily predict that this is the sequelae of irradiation from the appearance of the bone marrow of the vertebral bodies. You know that after irradiation there is fatty marrow conversion of the vertebral bodies, which are located in the field of irradiation. Then these vertebrae will be very bright in the T1 and also in the T2 weighted image, as you can see here, compared to the vertebrae outside the field of irradiation. And you see here that these vertebrae shows normal bone marrow signal in the T2 weighted image, and also the lower vertebral levels. But the vertebrae in the field of irradiation shows diffuse bone marrow fatty infiltration, which is one of the well-known sequelae of irradiation. Then we came to the sarcoid, and we discussed sarcoid 2 times before, in the chest and in the brain. You know that sarcoid is a granulomatous disease of unknown etiology, characterized by the formation of non-caseating granulomas, and the involvement of the CNS occurs in about 5% of cases. And in most of these cases, you can see pulmonary involvement as well. Meaning that whenever you are suspecting sarcoid in the central nervous system, you may have a chest radiograph or CT scan, and if there are manifestations of sarcoid, then you can reach the diagnosis. Then the most common manifestation of neurosarcoid is multiple cranial nerve pulses or deficits, and sometimes in many of the, about 50% of the cases may be asymptomatic. Then you know that sarcoid in the chest will show lymph node enlargement in the hilar regions, which are usually bilateral and symmetric. Sometimes you got enlargement of the paratracheal lymph nodes as well. And if you can appreciate the presence of interstitial pulmonary opacities, like these opacities scattered in both lung fields together with minute pulmonary nodules, then you can predict or suggest the possibility of thoracic sarcoidosis. And in the brain, you got the well-known manifestations, which mainly affect the leptomeninges and the dura, and also it can affect the Virchow-Robbins spaces with inflammation or lesions along the course of the cranial nerves. And in this case, you can see that there is significant meningeal thickening and enhancement along the convexity of the brain, as well as along the falx cerebri, and we call this Becky meningitis. And this is one of the manifestations of sarcoid and other diseases as well. But as I have said, and you can confirm the diagnosis of sarcoid from the presence of other lesions, particularly in the chest. And these are the common sites to be affected by sarcoid in the central nervous system, starting by the hypothalamus, which is the most common, then the brainstem, then the brain parenchyma, and lastly the cerebellar hemispheres. Then this appearance is one of the peculiar manifestations of sarcoid, but it, as I have said, it can occur in other diseases, which is leptomeningeal thickening and enhancement. And you see enhancement along the cerebellar folia, enhancement along the surfaces or the surface of the brain as well. Then in order to reach the diagnosis, as I have said, the clinical history may be helpful and other imaging findings, especially in the chest. You know that sarcoid can affect the bones or the musculoskeletal system, but the main brunt of the disease is usually seen in the chest. And sarcoid will lead to a form of myelitis, and the myelitis will appear of low signal in the T1, high signal in the T2, but very particularly if you inject contrast media and you got this characteristic or highly suggestive appearance, which is leptomeningeal sheets and nodules, enhancement of enhancing lesions along the borders of the spinal cord as well as in the basal cisterns. As I have said, this is not pathognomonic for sarcoid. It can be seen also in leptomeningeal metastasis or CSF seedling of tumors. And in order to reach the diagnosis, and you should have the history. If there is a known primary malignancy which can lead to leptomeningeal metastasis, and you should suspect this. But in absence of a known malignancy, this will include a differential diagnosis of sarcoid, leptomeningeal metastasis, and you remember also some cases of acute demyelinating encephalomyelitis. This is also an appearance of sarcoid. There is diffuse swelling of the spinal cord with diffuse increase in the T2 signal of the cord parenchyma and the cervical region. And after contrast injection, you got, let's say, masses or big lesions along the dorsal aspect of the cord showing contrast enhancement. This is the typical appearance of sarcoid in the chest, and you got bilateral, almost symmetrical enlargement of the hilar shadows, showing the lobulated or festooned appearance, denoting the presence of lymphadenopathy. Then if you look to the CT scan and you see the classic appearance of lymph nodes, which are discrete, they are homogeneous without areas of breakdown, and they may contain calcium. These nodes are almost pathognomonic for sarcoid inside the chest. This is neurosarcoid with follow-up after 4 weeks. And the T1 weighted image, and you see here, this is T1 post-contrast, the follow-up of this. There are big lesions that have been totally regressed, and also the diffuse intramedullary high signal intensity has been also regressed. And this is one of the criteria of sarcoid showing regressive course with treatment. And this is one of the cases that I have seen in the bracts. This is the female patient presenting by right lower limb weakness, and the MRI of the dorsal spinal cord showed a well-defined homogeneously enhancing lesion inside the cord parenchyma. And we suspected the possibility of sarcoid, and we did the CT scan of the chest, and we can appreciate the presence of enlargement of the mediastinal lymph nodes, which are homogeneous, discrete, almost classic nodes for sarcoid. Then after 6 weeks of therapy, this is the follow-up study of the dorsal spine showing complete regression of the disease. And one of the manifestations of sarcoid in the brain is this abnormal behavior. And here you can see there is involvement of the hypothalamic hypophyseal axis and this is, as I have said, one of the common locations for intracranial involvement by sarcoid. And you can also appreciate the leptomeningeal thickening and enhancement. Then we came to an inflammatory lesion, which is also well known in the spinal cord, which is the schistosomiasis. And this lesion has multiple criteria for the diagnosis. The lesion is almost confined to the region of the conus medullaris and is frequently seen in patients in the first or in the second decades of life. And of course, there are a lot of manifestations in the clinical picture related to involvement of the cones. In the all imaging, before the era of MRI, we used to do this contrast myelography of the dorsolumbar region, and to support this by CT myelography. And you can appreciate that the conus is swollen, and here also you can see that the conus is swollen as indicated by attenuation of the contrast column around the region of the conus medullaris. Then by MRI you can see the classic appearance of schistosomiasis or bilharziosis of the conus medullaris. The conus will be swollen. In the T1 weighted image, it may not show any signal abnormalities, but in the T2 weighted image, you will appreciate that there is some parenchymal increased signal. After contrast injection, many times you got nodular and patchy enhancement within the affected conus. And this classic appearance may obviate the need to biopsy this lesion, because early in the MRI days, we used to diagnose this as ependymoma of the conus, and this misdiagnosis has resulted in many biopsies. But actually, the detection of other bilharzial lesions elsewhere in the body, and the detection of bilharzia ova in samples taken from the conus medullaris is pathognomonic for the diagnosis. This is bilharzioma of the conus. The conus is swollen, and in the T1 weighted image you may not appreciate any pathology. In the T2 weighted image you can see some increase in the parenchymal signal. But what's very important here is the contrast enhanced images, where you can appreciate that there are multiple nodular and patchy areas of contrast enhancement within the involved conus medullaris. Actually, with the classic age of presentation, and you may have samples from the lesion, and you can detect the bilharzia ova as well as the chronic inflammatory cells, diagnostic of bilharzioma of the conus medullaris. Then intramedullary tuberculomas are considered rare, but this is an example, and you see lesion which is very small, located inside the substance of the lower dorsal spinal cord. After contrast injection, in this T1 fat suppressed image, you can see the classic appearance of tuberculoma, which is almost similar to that in the brain, showing the buttonhole configuration. Then many times you can also see concomitant TB manifestations in the chest, as you know that these tuberculous infiltrations are commonly seen in the upper lobes, especially in the apical and the posterior segments in the form of strandy nodular opacities. Sometimes you got cavities and calcification, as I have explained in details in the sector of thoracic imaging. Then we came to the infections of the spinal column, and the pathognomonic feature of inflammation in the vertebral column is the involvement of the disc, and this is the major diagnostic sign to suggest that the pathology you are dealing with is in the form of an inflammatory lesion. Whenever you see that there is involvement of one of the intervertebral discs, as well as the adjacent part of the vertebra above and the vertebra below. Then osteomyelitis and discitis are the major findings in cases of inflammatory infections, in cases of infections of the vertebral column of whatever etiology. And sometimes these two items may lead to the formation of epidural or subdural abscesses, and the abscess may extend inside the substance of the spinal cord, and also it may result in arachnoiditis if it is present in the lumbar region. And these are the sequelae or the changes of biogenic infection of the vertebral column in the form of vertebral osteomyelitis and discitis. The most common site is usually on the lumbar spine, but it can be seen at any other levels. This is the normal appearance of the intervertebral disc and the vertebrae, and starting inflammation of the disc itself, as well as the adjacent vertebral end plates, will result in loss of height of the intervertebral disc, as well as erosive changes of the adjacent vertebral end plates. Then you got diffuse bone marrow edema of the involved vertebrae, and you got also a lot of water within the disc substance, which will lead to increase in the T2 signal of the disc, as well as the edematous vertebral bodies. And finally, you got some sort of loss of height and partial collapse with almost loss of the disc space, and consequent you got some deformities in the spine, which will lead, of course, to nerve compression and many of the symptoms. And the discitis and the osteomyelitis, as you can see here in this upper dorsal region, you can compare this level by the level below or above. Here you can see the vertebral end plate, which is intact, and the disc space is well preserved. But here there is erosion of the vertebral end plate and marked narrowing of the disc space associated with a significant amount of paravertebral inflammatory granulation tissue. And this is also evident in the axial image. You can see the erosive changes in the costovertebral junction, the inflammatory granulation tissue on both sides of the vertebra. An MRI, and this is quite evident. In the dorsal region, you got involvement of the disc space as well as the vertebra above and the vertebra below. This will show low signal in the T1 weighted images, high signal in the T2 weighted images, and of course diffuse post contrast enhancement. And you remember, or you should remember, that bone marrow edema of whatever etiology, traumatic, inflammatory, neoplastic, will enhance after injection of contrast mean. Bone marrow edema of whatever etiology If you inject contrast, it will enhance. Then this is bone marrow edema in the vertebral bodies, and it will enhance after injection of contrast. What's very important here is the involvement of the disc in order to suspect the inflammatory etiology. And also you can see an inflammatory granulation tissue anterior to the vertebra, and more importantly posterior to the vertebra inside the spinal canal epidural in location compressing the spinal cord. And this, the anterior prevertebral inflammatory granulation tissue is seen in the axial images, and also the intraspinal component can be seen in the axial images. However, it is better appreciated in the sagittal images, as you can see here. Then this is the discitis, osteomyelitis, or biogenic infection of the spinal of the lumbar spine at the level of L2-3, with involvement of the disc, erosion of the vertebral end plates, and diffuse bone marrow edema of the vertebra above and the vertebra below. If you look carefully to the disc in the T2 weighted images, and you can appreciate that there is a lot of water in the disc substance, which is very bright in the T2 weighted image compared to the above and lower discs, which are degenerated. And commonly you see as staphylococcal infection, then followed by Escherichia infection, Pseudomonas klebsiella, and Salmonella can be seen in patients with sickle cell anemia. This is also a spondylodiscitis, or inflammation of the spine and the disc. The two vertebral bodies as well as the intervening disc are inflamed. The disc showed bright signal in the T2 weighted image, denoting the increased water content due to infection, and the bone marrow edema affects the vertebral body above and below the disc. There is some intraspinal extension of the inflammatory granulation tissue, which is not compressing the core. In the axial image, you can see the inflammatory granulation tissue in the prevertebral and paravertebral areas. This is C5-6 discitis and osteomyelitis, T1 weighted image. C5 and 6 are partially collapsed with destruction of the vertebral end plates and involvement of the disc. Intermediate signal in the T1, a high signal in the T2. And you look carefully to the prevertebral space, and you see a good amount of inflammatory granulation tissue extending above and below the affected disc level, and also inside the spinal canal, and you can see the epidural inflammatory granulation tissue compressing the cord. After contrast injection, the prevertebral inflammatory granulation tissue as well as the intraspinal epidural tissue also shows contrast enhancement, together with enhancement of the vertebral bodies as well as the intervening disc space. And this is biogenic discitis at the level of L2-3 disc. There is low signal of the disc, increased signal in the T2 weighted image, and enhancement of the disc as well as the adjacent vertebral end plates. The vertebral end plates showed bone marrow edema and the T1 weighted image, and this bone marrow edema is associated with some degree of bone sclerosis, because in the T2 weighted image still you can see that the end plates appear relatively dark. Then whenever you see the developing of a sclerotic reaction, then you know that this inflammatory process is going to heal. And this is an example of healing biogenic discitis, or healed, where you got bony sclerosis of the opposing vertebral end plates, and of course the disc will be narrowed because of the loss of the disc material, and there is absence of signs of acute inflammation. And this is what we call healing or subacute biogenic discitis. The disc space is narrowed. There is a developing bony sclerosis of the opposing vertebral end plates. But in this case, still you can see that the disc substance is full of water, and it shows very bright signal in the T2 weighted image. You can also see or appreciate the presence of inflammatory granulation tissue inside the spinal canal in the epidural space compressing the cecum. This is the biogenic infection of the spine with signs of healing. And here is a list of the signs which can be seen on imaging to suspect that the process is healing or healed. Persistent disc space narrowing, loss of T2 signal of the disc, resolution of the bone marrow edema, resolution of the epidural abscesses, and at last fusion of the vertebral bodies. And here you can see this is an active disease which is passing to healing. And here you can see the significant bone marrow edema and the involvement of the disc substance with enhancement of the disc as well as the adjacent vertebral end plates, together with the inflammatory granulation tissue inside the spinal canal as well as anterior to the affected vertebrae. But in the follow-up study, you got less brightness within the disc space, you got sclerosis of the vertebral end plates, you got almost total resolution of the intraspinal inflammatory granulation tissue compared to the above image, and also resolution of the prevertebral inflammatory granulation tissue. Then this is a good point. You remember in the degenerative disease of the spine, I have mentioned this type of bone marrow degeneration, which is type 1, where the disc space is narrowed, the disc is of dark signal, and there is edema of the vertebral end plate above and the vertebral end plate below. And this is known as type 1 bone marrow edema. And how can you differentiate this degenerative changes from inflammatory changes? The most pathognomonic feature is the appearance of the disc in the T2 weighted image. Here, the disc is degenerated, it will appear black in the T2 weighted image, but here the disc is inflamed and it is full of water and inflammatory granulation tissue. It will show very bright signal in the T2 weighted image. Then bone marrow edema around the inflammation may be sometimes more than the bone marrow edema around the degenerated disc. Also, in cases of infection, you may see erosive changes of the vertebral end plates, and in cases of degeneration, you do not usually see erosive changes of the vertebral end plates. Then these are the main differences between degeneration or bone marrow edema, degenerative secondary to degenerative disc lesion, and bone marrow edema secondary to discitis. Then extension of the inflammatory process inside the spinal canal may result in epidural or subdural abscesses, and the intraspinal abscess is almost similar to any abscess elsewhere in the body. There is a lesion which shows uniformly enhancing margin, as you can see here. This is T1 weighted image and this is T1 post contrast. This is the spinal cord and this is the abscess I mean. In the T1 weighted image before contrast, you may not appreciate the lesion, and also in the T2 it's difficult to appreciate the lesion, but in the T1 post contrast it's very clear. You see the enhancing margin which is of uniform thickness, and the abscess content which is of low signal in the T1 and high signal in the T2. This is also an epidural abscess, and here you see in the T2 weighted image the margin of the abscess is dark and the contents of the abscess are of bright signal in the T2. After injection of contrast you get marginal enhancement, and the margin is usually of uniform thickness, as you can see here, and also you can appreciate the abscess posterior to the spinal cord in the axial image. Then we came to arachnoiditis, and the arachnoiditis means inflammation of the arachnoid membrane. and there are a lot of causes, but surgery and trauma are usually the two main etiologies for this arachnoiditis. If the arachnoid membrane is inflamed, this will result in adhesion between the coda equina nerve roots, and the nerve roots will get adherent together, or they will get adherent to the inner aspect of the wall of the cecal sac. Then normally in the CT myelography, you see the cecal sac which is opacified by contrast and multiple dots representing the coda equina nerve roots. If the coda equina nerve roots are adherent together, they will form a shadow like this, or if they are adherent to the inner wall of the cecal sac, and you got that the cecal sac looks as if it is empty of the nerve roots. The nerve roots are adherent to the inner wall of the cecal sac and you cannot see them. This is known as pseudocord sign, and this is known as empty cecal sac sign. Then normally you can see the coda equina nerve roots like this. But if the coda equina nerve roots are adherent to the inner wall of the cecal sac, you got what's known as empty cecal sac sign. If they are adherent together at the center of the cecal sac, and you got the sign which is known as the pseudocord sign, since there is no spinal cord in the lumbar region at that level, for example. Then this is a form of arachnoiditis. This is normal. The nerve roots you can see here, but here you can see that some of the nerve roots have been adherent together here and there and there. This is this sign has no name, but either you have the empty cecal sac sign or the pseudocord sign or other configurations like this one, for example. And this is the empty cecal sac sign. The nerve roots are adherent to the inner wall of the cecal sac. And this is the pseudocord sign. The nerve roots are adherent together, forming as if there is a cord in this particular segment, but there is no cord here. Then we came to a very important type of infection, which is TB. And I have to say that, and this is well stated in the literature, that tuberculous spondylodiscitis may be difficult to be differentiated from pyogenic spondylodiscitis. And in the early days before MRI, we used to differentiate both by the presence of abscesses in the paravertebral area, and we thought that if there are big abscesses in the paravertebral area, especially if they involve the psoas muscle and the back muscles, we call this of tuberculous etiology most likely. But nowadays you can see huge abscesses of non-specific organisms like Staphylococcal aureus, for example. Then the infection of the spine by TB is usually the sequelae of pulmonary tuberculosis, leading to hematogenous spread of the organism to the spine. And the major manifestation of any infection in the spine is involvement of the disc, as well as the above and the below vertebral end plates. Then one of the pathognomonic features of TB is that it can spread underneath the anterior longitudinal ligament for long distances above the level of infection. Also, the involvement of the posterior elements is considered less frequent compared to pyogenic discitis. Then here you can see broadening of the superior mediastinal shadow, and in the CT scan you can see the typical appearance of abscesses, hypodense lesion with uniform marginal enhancement, multilocular abscesses together with erosive changes of the vertebral bodies as well as the intervertebral disc, may suggest the possibility of TB or pyogenic infection. And here you see infiltration of the vertebral body, it's erosive changes, prevertebral multilocular abscess, and also abscesses in the back muscles. as I have said, we used to think of tuberculous etiology whenever we see these abscesses affecting the muscles, but nowadays the two possibilities are there: pyogenic and the tuberculous infection. Then if you look here at the level of D11, 12, there is some loss of height of D11 and D12 as well, with erosion of the vertebral end plates and narrowing of the disc space. This is well evident in the CT scan, sagittal reconstructed image, that you can appreciate the destructive changes in the vertebral end plates as well as the intervening disc. And if you look carefully in the frontal radiograph of the dorsal spine, and you can see the paravertebral soft tissue component. One of the features of TB and other inflammatory processes in the spine is to cause gibbous deformity because of the collapse of the involved vertebrae and loss of height, and you got kyphus deformity at the level of the lesion. As you can see here, there is involvement of the disc as well as the above and below vertebrae with inflammatory granulation tissue anterior to the vertebral column, as well as inside of the spinal canal compressing the distal part of the cord. After injection of contrast, you get enhancement of the involved vertebrae as well as the intervening disc, together with the inflammatory granulation tissue. And this is also an example of tuberculous osteomyelitis at L2-3 level. There is subtotal destruction of L2 and L3 vertebral bodies with involvement of the intervening disc space, as well as multiple para and retrovertebral abscesses involving the psoas muscle as well as the back muscles. This is also spinal tuberculosis. By the plain film, you can see collapse of one of the vertebral bodies with involvement of the disc, and you cannot appreciate involvement of the above vertebra. But in MRI, this is not the same case, of course, and you can appreciate the affection of the vertebrae, and more importantly, the detection of inflammatory granulation tissue inside of the spinal canal. Then one of the features of tuberculous spondylitis is the subligamentous spread of the inflammatory process. And here is a good example. There is a lesion at that level. This is C2, 3, 4, 5, 6, and 7. Then C6, 7, there is a tuberculous lesion or spondylodiscitis involving the disc as well as the vertebral body, and there is a prevertebral abscess which is extending underneath the anterior longitudinal ligament for a good distance below the level of the lesion. The abscess will show bright signal in the T2 weighted image, and it shows marginal post-contrast enhancement, as you can see here in this image. This is also subligamentous spread. You can appreciate the involvement of these vertebrae, but here, which is one of the features that make the diagnosis of spondylitis somewhat difficult, is that the disc spaces are not involved. And subligamentous spread is one of the well-known criteria of TB. Many times it can affect the anterior border of the vertebra, and sometimes it do not involve the intervening discs. Then whenever you see what is known as skip lesions, and this is highly suggestive of tuberculous spondylitis. And by skip lesions, you can see multiple levels of inflammatory process along the spinal column. And near at this is C2, 3, at C4, you got the collapse of the vertebra and a huge prevertebral abscess compressing the pharynx. Then lower down you got another inflammatory lesion, and also lower down you got another inflammatory lesion. And this by this what we mean the skip lesions, which are usually suggestive of tuberculous spondylitis. This is another example of a skip lesion. There is a lesion here, and there is also another lesion there. Then what are the suggestive features for the diagnosis of tuberculous spondylitis? According to the literature, if there is subligamentous spread for 3 or more levels, if there are multiple involvement of vertebral bodies, or involvement of the entire vertebral body with prevertebral abscess, or the presence of paraspinal abscesses, especially if large and containing calcium. This is also one of the pathognomonic features of TB, and as I have said, that the skip lesions are one of the supportive criteria for the diagnosis of tuberculous spondylitis. Then brucellosis is an inflammatory lesion of the spine. The organism is present in unpasteurized milk, and it penetrates the lymphatics from GIT to the reticuloendothelial system, reaching to the spine, forming a lesion which is almost similar to TB, except for some of the differentiating points. This lesion, the brucella, usually affects the lumbar spine, particularly the distal part of the spine. And this disease, the vertebral height is preserved, so you do not get spinal deformities or kyphosis or something like this. Also, you do not see paravertebral abscesses as is well known in the biogenic or tuberculous spondylitis. No spread to the intraspinal or to the spinal canal, since then there is no a chance for the formation of epidural abscesses, for example, and there is no involvement of the posterior elements. Also, one of the supportive diagnostic criteria is the presence of osteophytes and bone sclerosis at the level of the lesion, especially this kind of osteophyte, which is similar to the parrot beak, for example, and you got at the area of infection together with erosion, and you can see also a sclerotic reaction. And this is the sequelae of brucella spondylitis or spondylodiscitis, and you got localized area of bone erosion in the anterior part of the vertebra adjacent to the disc. Then there will be an active area of bone sclerosis similar to this one, and you see erosive changes adjacent to the disc, then active area of bone sclerosis, then a small area of gas, or what's known as the vacuum phenomena, entrapped between the vertebral end plate and the disc. Then you got this classic osteophyte, which is similar to the parrot beak, this one, and this is one. Then if you have the MRI, you may not be able to predict that this is the brucella spondylodiscitis, and here you can see 2 levels of involvement. But look carefully, these are not 2 levels. This level is infection and this level is degeneration. And here, how can you differentiate? This edema and the involvement of the disc with erosive changes of the vertebral end plate and some brightness within the disc substance. But here you can see that the disc is degenerated. It is of low signal in the T2 with reactive bone marrow edema in the opposing vertebral end plates. This is also known in the literature that the diagnosis is usually reached via the positive blood culture or positive serologic results. If you have biopsy from the lesion, you will not reach a specific diagnosis since the organism is difficult to be cultured. Then you may diagnose this as spondylodiscitis of whatever etiology, and you may think of biogenic or tuberculous spondylodiscitis, but the absence of significant destructive changes in the vertebral end plates, may suspect the possibility of brucellosis. An infection by the fungus will lead to non-specific imaging findings which cannot be differentiated from those of biogenic or tuberculous osteomyelitis. You got involvement of the disc as well as the vertebral bodies, together with prevertebral inflammatory granulation tissue as well as intraspinal extension in the form of epidural or subdural abscesses. Then here, if you look in, you can see some erosive changes in the vertebral end plates, narrowing of the intervening disc, and a good amount of pre- and paravertebral inflammatory granulation tissue, which is not which cannot be differentiated from biogenic or tuberculous osteomyelitis or spondylodiscitis. This is one of the findings which is suggestive, maybe suggestive, is the preservation of the nuclear cleft of the disc, which is not seen in any other type of infection. I am not sure about this, but if you look here and you know that this low signal line within the bright disk in the T2 weighted image is known as the nuclear cleft. And if you look here, you may assume that this black line is the nuclear cleft which is preserved. Then you think of fungal infection. I am in doubt of this. And this is not a supportive criteria, but if you look here and you see at L2-3 level, there is an inflammatory spondylodiscitis with brightness of the intervertebral disc, enhancement of the disc and the vertebral bodies, together with inflammatory granulation tissue inside the spinal canal as well as in the prevertebral area. Sometimes we deal with this as a tuberculous spondylodiscitis, and the patient is given anti-tuberculous treatment, and if he is not improving, we may have a biopsy from this and culture the organism to reach the final diagnosis. One of the parasitic infections of the spine is the hydatid disease or echinococcus disease, and this is a lesion which, in my opinion, is very easy to reach the diagnosis. Before the era of MRI, we used to have the myelography, and in this particular case, you can see that there is total obstruction of the spinal canal to the flow of the contrast column at this level. The CT scan showed that there is multiple intraspinal cystic lesions with well-defined margin and almost a clear fluid content. These cystic lesions are also seen in the prevertebral area, and I think if you can appreciate these findings, especially in the CT or MRI, you can easily suspect the diagnosis of hydatid disease of the spine. And you know that one of the most pathognomonic features of hydatid disease is the presence of a big lesion with multiple mural daughter cystic lesions along the periphery of the lesion. If you see this, and you know that this is a hydatid cyst anywhere in the body. But if you look for this particular lesion and you see there is erosion of the vertebral body, and there is the prevertebral soft tissue component which is partly cystic and partly solid, there is marginal calcification. You may think that this is inflammatory, and you may also think that this is neoplastic, and sometimes we need to biopsy a lesion like this to confirm its nature. And also here, and you can see that there is a lesion infiltrating the vertebral body, the right side, with extension into the paravertebral space in the form of multilocular cystic lesions. Then one of my advices to you is to consider the possibility of hydatid disease if you see multiple cystic lesions involving the vertebral body as well as extending inside the spinal canal, and you may have also cystic lesions in the para or prevertebral area. One of the associated features is the presence of calcium in the wall of the cyst and the presence of bone sclerosis in the vertebral body, which is involved by this disease. One of the suggestive features is the detection of hydatid disease elsewhere in the body. Like in this case, you may see a hydatid cyst in the brain, and you may see a hydatid cyst in the lung, and this is a hydatid cyst in the spine. You see multiple cystic lesions in the prevertebral area inside the spinal canal as well as in the retrovertebral area. And this is also a suggestive appearance of hydatid disease. There are multiple cystic lesions of high signal T2 content in the paravertebral area as well as inside the spinal canal, and these features, as I have said, usually suggest the possibility of hydatid disease of the spine. Thank you very much. Alhamdulillah Rabbil Alameen. Assalamu alaikum wa rahmatullah.